Okay, I've got 12:03 and a great critical mass is on here, so we're going to go ahead and get started. Good afternoon. My name is Kelly Cannon, and I'm the CEO of the VHHA Foundation, which is the philanthropic arm of the Virginia Hospital and Healthcare Association. We are so proud to partner with the Virginia Neonatal Perinatal Collaborative and other state and national partners to present this webinar series on the data available to healthcare and community providers and the public to improve maternal and infant health outcomes. This topic is unfortunately both timely and grave. While global maternal mortality rates have declined in the past 2 decades, they have risen in recent years in the United States and here in Virginia. According to the CDC, the U.S. maternal mortality rate in 2021 was 32.9 deaths per 100,000 live births. In Virginia, pregnancy-related mortality rose from 12.3 deaths per 100,000 live births in 2019 to 32.4 deaths per 100,000 live births in 2021. Together with our partners, we believe that accurate and comprehensive data is an important component of quality improvement in healthcare. We know that healthcare providers cannot move this trend alone, and it will require partnerships with community-based providers and public entities to make a difference for birthing people and babies in Virginia. We're very grateful to Delegate Charneil Herring for proposing legislation 2 years ago, which launched the Maternal Health Data Task Force, which led to the proposal of this webinar series. Today, we will kick off the series with a presentation from Andre Tolleris, Director of Data Analytics at VHHA, and Evan Isaacs, Data Analyst with the VNPC. Our upcoming webinars will include presentations from Virginia Department of Medical Assistance Services, the Virginia Department of Health, Virginia Health Information, and the Office of the Chief Medical Examiner. You can register online for the remainder of the series. We'll drop that link in the chat. And please share this information with your colleagues and partners. At this time, I'll turn things over to Andre.
Good afternoon, everyone. My name is Andre Tolleris. I'm the Director of Data Analytics at the Association. And I will be presenting the VHHA Maternal Health Dashboard. And we'll be going through some slides today. Evan will be leading us on those slides. Appreciate all of the intro, and I'll turn it back over to Evan.
Awesome. Hi, everyone. I am Evan Isaacs. I am a data analyst with the VNPC, and we're really excited to showcase this maternal health dashboard. This is something that the VNPC and the VHHA have been working on together for a long time, and it really helps our work a lot, so we're proud to show it off. And I'll kick it back to Andre to give us kind of the overview of where the data comes from and how it gets there.
Absolutely. Thanks, Evan. So the way that the flow of this data works is that there was legislation passed in 1993 that created a patient-level data system, which is essentially a central data repository where all private hospitals and health systems in the state of Virginia submit their inpatient data to on a quarterly basis. And so that data has been submitted to both the state through Virginia Health Information, or VHI, and also it's submitted to us at the Hospital Association at VHHA. And so the legislation really mandates hospitals submit their inpatient data specifically. And so the inpatient data that's submitted is discharge data. You can think about it as essentially pre-adjudicated claims data. So when a service is rendered and a hospital wants to bill the inpatient encounter, they do that through UBO4, which is the standardized method of billing for institutional providers. In this case, hospitals are institutional providers. And so that UBO4 claim form has a lot of really helpful data elements that we can use to do analyses related to a variety of different fields within healthcare. In this case, specifically maternal health, we have access to all 85 diagnosis positions or diagnosis codes. We've got all of the procedure codes. We've got patient race and ethnicity, zip code, county of patient origin. We've got a ton of other patient demographic factors in this data. And so that is the summary of the discharge data that powers this maternal health dashboard, is that we are essentially filtering this massive inpatient database, this massive statewide inpatient database, and we're looking at the data trends from there. We do also receive limited outpatient data, although doesn't have the same sort of historical data time frame. It only goes back a few years, and unlike inpatient, there aren't really the same sort of stringent regulatory reporting requirements for hospitals to submit their data on a quarterly basis for outpatient or the emergency department as there is for inpatient. So we're going to be looking at inpatient. So these are all reflective of in-hospital birthing volumes, which we know is not the 100% of the picture, but it's still directionally, I think, important. And so all of the hospitals are represented in this data. VHHA represents all health systems in the state. They're all our members. And so when we're looking at these discharge trends, you're looking at statewide, all hospitals and health systems, and you're looking at in-hospital birthing volumes. And with that, turn it back over to you, Evan.
Awesome, thank you. I'm going to cover some of the advantages with our maternal health dashboard. And the hospital discharge data are very reliable with that legislative regulations. By mandating facilities submit their patient data, it is very complete, and we do get a lot of records that way. The dashboard is updated quarterly, which in terms of data, especially with this scale, is very quick. Every facility in Virginia that housed an inpatient birth is represented in the dashboard. And then we're able to compare variables at statewide aggregate levels, and we're also able to drill all the way down to look at the individual facility or zip code. And sometimes this is very useful when partnering with our facilities to be able to show them like kind of the nitty-gritty of the patient demographics. And then we also have a huge availability with all ICD-10 codes from records to have a wide range of analysis. So recently we've been looking at obstetric hemorrhage, mental health with depression and anxiety, substance and alcohol use, and we also look at severe maternal morbidity through this dashboard. And this gives us nearly unlimited potential for demographic stratification. We have access to racial factors, payer, age, length of stay, facilities, zip codes, delivery type, and we have even created a few customized flags. So we have one for mental health, and then we just created a new one for obstetric hemorrhage that has already come in very handy. And despite all these advantages, there are a few limitations or areas for improvement. So only inpatient data are represented in this dashboard, and being able to link with outpatient and emergency data, we could expand to have a more complete picture of maternal care in Virginia. And also understanding readmissions could shed more light on areas for quality improvement initiatives. We are not able to see deliveries for Virginia residents that occur outside of Virginia, and this is kind of important at more of our border areas towards the north. There might be people who are going into Maryland to give birth, and there's also people in the south going into North Carolina to give birth. And so these are deliveries that are not represented in this dashboard. We have also not yet identified infants in this discharge data, and I think Andre and I have already begun evaluating how that can be done and kind of expanding this data into an infant health data set too. And finally, the high sensitivity of this data does cause limited public access, and I will cover more later about who can see this data and who it belongs to, things like that. So how is the dashboard used? VNPC pulls data from this dashboard to support our statewide quality improvement projects. our project Equitable Care for Mothers and Babies Through Readiness, Access, and Community Extension, also called Embrace, provides each partnering hospital with access to this database. And this can help with their PDSA cycles to highlight outcome measures for quality improvement initiatives that they are carrying out at their facilities. And then also at the VNPC, we create curated reports for hospitals as needed. Recently, we created obstetric hemorrhage report for one of our partner hospitals, and that is actually how we ended up adding this obstetric hemorrhage flag onto the dashboard. And I am still rather new with VNPC. I just started in October. And so my hope with the future is that we're able to utilize this dashboard more to produce more published reports on like more emerging health trends. And then finally, who can access the dashboard? So the VNPC has partnered with the VHHA to construct this dashboard. So we both have full access, although only the VHHA has the oversight to make changes to the dashboard. But we are able to make suggestions. VHHA partner hospitals are the owners of this data, and so they are also permitted access. And the VNPC can create private reports for hospitals participating with quality improvement efforts. And then finally, public-facing options, while somewhat limited due to the sensitivity of this data, include VNPC or VHHA published reports with aggregated data. And it's important to note that we won't publish any data specific to any hospitals or individuals when we do so. And before we move on to a live demo of dashboard, I just want to make sure if there's any questions we can answer at this point. It doesn't look like we have any questions, so I think we can move on. Andre, I'll let you take it from here.
All right, thanks, Evan. I'll go ahead and share my screen. All right, can everyone go ahead and let me know if you can see my screen, Evan? Can you see it?
Yep, I can see it.
Okay, perfect. So this is the maternal health dashboard published on the VHHA Analytics platform titled VHHA Analytics. It's run through Tableau Server, which is a data visualization software. And so we house the report, this actual dashboard that we'll be looking at today on Tableau Server. We have our own Tableau Server. And so that's where our analytics platform is, and that's where this lives. So what you're looking at right now is the total number of in-hospital births from Q1 2017 through Q3 2023 for all private hospitals and health systems in the state of Virginia. And so you can see the total number of births during that time period. It's important to note that Q3 2023 is the most recent data that we have available. We will be having data through Q4 2023 relatively soon, within the next couple of weeks. And so that's kind of a testament to the timeliness of our data. But that being said, you can see the annual birth volumes right here. And really what this is saying is that the total number of in-hospital births decreased during the pandemic. And although we've started to see trends increasing, it still hasn't quite reached pre-pandemic levels of about 91,000 births, in-hospital births every year. We're still just shy of 90,000 as of 2022. If you look at the middle, you can see the average length of stay for all in-hospital births. That's about 3.2 to 3.3 days on average over this roughly 5.5 year time span. There's also a heat map of zip codes where the darker red zip codes indicate higher volumes and the lighter yellow color indicates lower volumes for in-hospital births. And then at the bottom, you can see a series of bar charts that show the percentage of discharges, so discharge volumes by patient race, chronic condition, payer, and the patient zip code. And in addition to the user being able to click on any one of these fields to filter the data on any one of these bar charts, you can also filter the data at the top with a standard set of filters that we include in almost all of our dashboards. We can really get granular. So let's say I'm looking at this number and say, okay, I know that roughly 90,000 births on average over the past 5.5 years. I'm interested in looking at Medicaid births or trends in hospital births for Medicaid patients specifically. I can click on this bar chart for Medicaid and the data will update automatically. And so I can see that Medicaid discharges comprise roughly a little over a third of all in-hospital births in the state. And I can see that although the trends statewide for all payer are still approaching pre-pandemic levels for 2021 and 2022 for Medicaid, it looks like that's kind of bucking that trend. We've already exceeded pre-pandemic levels for Medicaid patients. If I look at, let's say I'm looking at Medicaid specifically, and I want to look at a specific zip code, and I see that the zip code 23224 is the zip code with the highest volume of in-hospital births for Medicaid patients, I can click on that. And then the data will update so that I know for this zip code, the patient race stratification, the stratification of different chronic conditions. So I know that over 50% of all the in-hospital births over the past 5.5 years for Medicaid patients in this zip code were for Black patients, followed by other specified, followed by white and Hispanic white. It's important to, oh, sorry, I thought I heard someone else. It's important to recognize that these are just the way that the patient race codes come in through the discharge data, and that other specified is frequently used as a race code when the patient is multiracial, and so it's not immediately known, or it's not recorded in the discharge that they are multiracial. Instead, it's other specified. So that might explain why that percentage is high. But for any one of these zip codes, you can slice and dice by Medicaid or commercial self-pay. You can look and see the total number of in-hospital births for mothers with anemia or obesity, and see how the trends, once you slice and dice the data by all of these different elements look like. And that can give you a better understanding if you're a member of a hospital analytics team. This can just give you a general starting point for quality improvement initiatives when it comes to maternal health. Or if you're someone at the VNPC, you can use this data to work with specific facilities. If I wanted to, I could filter to any hospital that offers delivery services. I can filter to any one of these hospitals here. I'm not going to do that just because I want to protect our members' data, but we've also got a severe maternal morbidity flag, delivery type, DRG description. So the way that we at the association currently define an in-hospital birth event is that we include any inpatient encounter with a DRG for either cesarean section or vaginal delivery. So right now, if I wanted to, I could filter and look at the rate of cesarean sections, keeping in mind there's about 90,000 births every year. I can see that cesarean sections comprise roughly a third of all in-hospital births in the state. And these numbers are consistent with what CDC Wonder has been reporting. And so that does put Virginia in the upper quartile of states in terms of the rate of cesarean section. We are one of the top quartiles when you stratify that data. And then another important kind of high level trend to point out is the trend in severe maternal morbidity and how that's increased in the past several years. And so you can see obviously the annualized totals increase, as well as the every quarter you can see overall higher volumes of severe maternal morbidity. But we define severe maternal morbidity in the dashboard as any in-hospital birth event. So any in-hospital birth event with one of those DRGs relating to a delivery, We use the list of CDC severe maternal morbidity ICD-10 codes to flag any one of those in-hospital birth events as severe maternal morbidity if they include one or any more of the codes included in the CDC list. So the numbers that you're looking at are, you should be able to back into them using publicly available data. And the trends are showing that the rates of severe maternal morbidity in the hospital have increased over the past 5.5 years, and that the rate of severe maternal morbidity is also higher for Medicaid patients, despite Medicaid patients only comprising a third of in-hospital births across the state. And so I'm going to keep flipping through the different tabs here, but we've got a ton of other different tabs, like tabs for stillbirths, tabs for obstetric hemorrhage, mental, behavioral, and neurodevelopmental ICD-10 codes present on the encounter. So can filter by all of those data elements as well, but I'll just keep plugging along here. So the second tab shows the total number of in-hospital births via bar charts for both vaginal deliveries and cesarean sections. You can see cesarean sections comprise roughly a third, maybe a little over a third in aggregate of all in-hospital births over this time frame. But then you can also, within each one of these DRG groups that we use to define maternal health, see the composition of the payers. So for cesarean sections, slightly higher proportion of those encounters being for commercial patients, roughly the same amount for Medicaid patients. And at the bottom, you can see also all of the individual DRGs that are grouped into the top two. So all of these DRGs are the actual DRG descriptions we use to pull in all of the data, and you can click on these like in the other tab. So if I wanted to look at the top DRG, which is vaginal delivery without sterilization, without major comorbidities or complications, I can click on that top DRG, and I can see the bottom half of the dashboard update. I'll just click on that again. And so I can see the age stratification. So this is just looking at the average age, the median age. In this case, it's filtered to a specific DRG, but if I look at all births, I can see the average age for in-hospital births is 30. The median age is also 30. And the age distribution here, as well as the composition of patient race. So 51.6% of all in-hospital births are for white patients, followed by 20.58% being for Black patients, roughly 12% being for other specified, roughly 6.58% being for Asian patients, so on and so forth. And we can also see the rate of in-hospital births where the patient race code isn't recorded or is unknown. So that a little under 5% of all inpatient records. But I think it could be interesting if you wanted to slice and dice the data using the filters at the top, or, if we clicked on one of the patient race groups, we can see, I'll keep clicking off of it here. If I click on one of the patient race groups, I can see that for Black patients, for both vaginal deliveries and cesarean sections, Medicaid comprises a higher share of the payer mix than for white patients. You can also see the average age for Black patients is about 1 year less than the statewide average at 29. If we look at Asian patients, the average age and median age is both 33, so on and so forth. So I can also, if I wanted to, look at this tab with the severe maternal morbidity flag turned on, and then I can see what the payer mix looks like. So actually, or not the payer mix, I can see what the DRG mix looks like. And so when I filter the severe maternal morbidity flag to yes, I actually see that only a third of all in-hospital births with severe maternal morbidity are vaginal deliveries, 2/3 are for cesarean sections. But if I look at the statewide data, it's actually the inverse, where cesarean sections comprise only 1/3. But if I look at severe maternal morbidity, it's actually 2/3 of all the discharges. So we can see that severe maternal morbidity is higher in Medicaid patients. And we can see also that it is higher for, or that severe maternal morbidity is more common in DRGs that reflect cesarean sections. All right, this third tab is pretty straightforward. It's just a line graph that shows the distinct count of in-hospital births by week, pre and post-COVID. And so there is some seasonality with in-hospital births that we've noticed. And that was obviously affected by COVID, but it seems like that seasonality is returning in subsequent years in 2021 and 2022. And then at the bottom, you've got the DRG breakout. So if I wanted to, I could click on any one of these DRGs and see the trend. In addition to looking at them in aggregate by payer and by DRG on the previous tab. And then the final tab is severe maternal morbidity. So I've gone over the severe maternal morbidity flag in a couple of other tabs, but this one specifically focuses on visuals for severe maternal morbidity. And you can see the rate of severe maternal morbidity, or what we're using to define the rate, which is the percentage of all in-hospital births with a SMM code, with a severe maternal morbidity code. So this is not population-based. This is just percentage of all discharges, a percentage of all birth events. But even still, that metric is showing that the rate of in-hospital births with a SMM code went from 0.57%, 0.57% in Q1 2017, and has increased to 0.79% of all statewide in-hospital births. And so if I wanted to show this by payer, I could show this and filter to, not Medicare, I won't have anything. It's filtered to Medicaid. So for Medicaid, that increase is more pronounced. Instead of 0.57 to 0.78 or 79, whatever it was, it's 0.59 to 0.88. And for commercial, the rate of severe maternal morbidity has also increased. So if I filter back to all payers, I can see the DRGs with the highest severe maternal morbidity rate. So unsurprisingly, DRG 783, which is cesarean section with sterilization with major comorbidities and complications, has the highest severe maternal morbidity rate of about 10.5% of all discharges with that DRG have a code that represents severe maternal morbidity. That being said, this DRG only comprises 0.4% of all discharges, of all total in-hospital births, but it's still, when you're looking at that DRG, it still has the highest SMM rate, despite it not having the highest overall volume. So we just wanted to stratify that, those low volume but high severe maternal morbidity rate DRGs. And then you can also see the rate of severe maternal morbidity stratified by patient race. So you can see that Black patients, followed by Hispanic Black patients and American Indian patients, have the highest rate of severe maternal morbidity. And it's higher than the statewide average. And then you can also look at the severe maternal morbidity rate by VHHA health district. We have a health district filter at the top, and health districts are just groupings by the Department of Health. They're groupings of counties. So you can see right now, Eastern Shore has the highest rate of severe maternal morbidity. And if I wanted to, I could click on that, click on that district, and I can see the rate go up and down. So Eastern Shore, 1.12% of all discharges have an SMM code. And I can see the trend at the top. So, and then the actual last tab of this is not really a tab. It's more so just a feedback form. So our members, or anyone that has access to this dashboard, if they want to get in touch with us, they can use this form and it'll send an email to our inbox. So if there's a question about the underlying methodology, or there's a request or a suggestion, or somebody sees an error, they can send us an email and we'll get back to them promptly. But that is a quick overview of the maternal health dashboard. Lots of different ways to slice and dice in hospital birth trends. Yeah, we use this with our members, in conjunction with our members. The VNPC, like Evan was talking about, uses this, working with our members directly to do analyses related to severe maternal morbidity, or the rate of OB hemorrhage and the category of hemorrhaging that's going on. So I think it's a really powerful tool. The discharge data that we have at our disposal is really robust because it has so many data elements that relate to patient demographics and also clinical elements as well. I think it's a really powerful data set that can be used for both policymaking and overall clinical quality improvement. And with that, I think that kind of wraps up my spiel about
Andre,
the
you have a few
dashboard.
questions in the chat.
Okay, yeah, we'll just open it back up to questions and we'll take a look here. Okay, so do you have any data on primary C-section versus repeat? So because we use just the DRG to define maternal health, in this case, to pull the record, the inpatient record for the mother specifically, if the DRG does not specify repeat C-sections, which it looks like the current list of DRGs that we're pulling in don't necessarily take into account, unless a repeat C-section would be grouped under a cesarean section with a comorbidity or complication, which I'm not entirely sure if that's the case. If a repeat C-section would be grouped under that DRG, then we would be capturing it. If it's not, we're not capturing it. To kind of answer that question, I know it's not, I know it's a little bit more nuanced, but if repeat C-sections are captured under the list of DRGs that we've shown, then it is included in this data set. Second question I see is, do hospital VNPC representatives have access to this Tableau report? And Evan, you already responded to that. So yes, they do provide access for hospitals participating with Project Embrace. And so where is this data being abstracted from? So I'm assuming that means, where is the data being pulled from? And so that is kind of what we covered a little bit at the beginning of the presentation, where all of this is discharge data that's being sent from the hospitals directly to both the state and us, which is the hospital association. And so whenever an institutional provider wants to bill a claim, in this case, an inpatient encounter for an in-hospital birth, or any inpatient encounter, they will bill that through a claim form called the UB04. And that UB04 has a lot of different clinical and patient demographic elements that we can use to visualize healthcare trends, in this case, in hospital birth trends. So that's kind of where the data is coming from. It's being reported directly from the hospitals. And there's somebody in the operations or IT side of the hospitals that are sending us, they're in direct communication with us and other partners to ensure that that data is submitted quarterly. Next I see is hypertension / preeclampsia, a DRG that is related to severe maternal morbidity. I believe it is. I don't have, let me actually pull up the list in front of me.
Yeah, I have the list pulled up. I can drop it in the chat too.
Yes, yep, that would be great. But I do believe that hypertension and preeclampsia are included. Or maybe I'm not correct. I'm actually looking at the list. But yeah, Evan will drop that in and make sure you have the right answer.
It looks like eclampsia is included, but not hypertension or preeclampsia. Yeah.
Yep,
Yep,
that's what I'm
got it.
looking at right now. Perfect. All right. Do local health departments have access to this dashboard? Great question. So no local health departments have access to this dashboard. The Department of Health does not have access to this dashboard. And the reason is because the underlying data, which is our members' data, our members' hospital data, is protected through pretty stringent data use agreements that we have. So essentially all of this data that's visualized here is it's frequently split up and stratified at the facility level. So we have like a hospital filter here where you can actually look at the rates of severe maternal morbidity for specific hospitals or a group of hospitals, specific patient race group or DRG at any hospital or health system across the state. And so our data use agreements do not allow us, specifically our members, to share their data with outside entities unless it's in aggregate. So that's what we're showing now. We're only looking at high level, statewide, unfiltered trends in the dashboard as to not provide any of our members hospital level specific data. But those data use agreements that our members have are, they are pretty stringent, and they do specify that unless we're sending the data statically, like pulling down a PDF of this report and sending it to a local health department in aggregate or VDH in aggregate, which we have done before, is just sending screenshots, static PDFs of the dashboard and distributing that to local health departments. That is something that we can do, but we do not provide direct access to local health departments at this time due to those data use agreements. And for that case, we do not provide access to the Virginia Department of Health. Next is, I'm seeing hypertension, preeclampsia. Okay, so I'm just seeing responses. Any other questions about this data? No data on neonates. Is that correct? Great question. So the actual inpatient database, the underlying inpatient database that we're pulling from does have data on neonates. It's just that the dashboard that we're showing is specifically related to maternal health, so it does not include neonate records. So when an in-hospital birth happens, 2 discharge records are produced, one for the mother and one for the baby, the newborn. In this case, we're using all the DRGs to pull the records specific to the mother so that when we're visualizing in hospital birth trends, we're not duplicating any of the records. And so for that case, we made the strategic decision to only pull records for the mom. But as Evan talked about earlier in his slides, we are working on creating a mirror dashboard of what we're looking at here, specific to neonates, specific to newborns. So actually pulling out the records specific to the newborn, doing the same visuals to monitor statewide in hospital birth trends for newborns. But that is not available right now. It will be released, I believe, in the next few weeks. And so it's not that the data doesn't exist, it's that we just haven't published anything about it yet. But that's a great question. Any other questions about the dashboard or in-hospital birth trends? Does the dashboard include self-pay patients? Great question. It does. It does include self-pay patients. So it is in the drop down here, but I can also click on self-pay at the bottom. So there's this payer bar chart. Right now I'm looking at roughly 3% of all in-hospital birthing volumes being for self-pay patients. If I click on that, the data will update. I can see the top zip codes for self-pay patients. Now, one thing that I think it's interesting is that when you look at in-hospital birth trends for self-pay patients, you can see the impact of Medicaid expansion as the rate of self-pay patients goes down after Medicaid expansion was passed. In 2018, the rate of patients stays the same, and then it's been going down ever since. And then if you look at Medicaid patients, that number has already surpassed pre-pandemic levels. So I think it's safe to assume that a lot of the self-pay patients that the dashboard was capturing pre-Medicaid expansion are now being captured as Medicaid patients in the dashboard if they're going back for another birth event, or if their payer code changes after Medicaid expansion was implemented. But yes, we do have self-pay patients. So that's also a big advantage of this data, is that it contains data for all patients in the hospital for any care really that's rendered in the inpatient. Even if the patient doesn't have insurance, or a really funky insurance, like some sort of faith-based cost sharing insurance, we'll have that data. Are there any plans, hopes to get data input from community organizations in the future? Absolutely. Absolutely there is. And I think that's something that we can, Evan, you and I can talk about a little bit more, is kind of our vision for engaging community organizations in the future and the strategy for how to get their input on this. I know that this data is not, this dashboard specifically, that live access isn't available to community organizations or health departments, but maybe just coming up with a plan to pull down PDFs of this report, send it out to those community organizations, and then get their feedback and kind of have that continuous feedback loop for continuous improvement in the dashboard would be really helpful. And so I think Megan does raise a important point that we should be kind of tackling that. And then is the data validated by record review even for a proportion, or is it just uploaded from the hospital administrative data? So we do have a standard data validation process that we do internally at VHHA, but also our partner, our vendor, the partner that actually is responsible for processing all of the data and compiling it from all of the hospitals into one central file. They have their own data validation as well. And so there are standard record checks in place. Like if there's, in one quarter, a massive drop off in records at a high level, or even a 20% drop off, it's something that we flag and highlight. Also, our data validation processes are pretty strict, as they're looking for typical data element errors, like having a field that's just blank, whereas it should be populated, or, so just looking at fields that are required to be populated, if they're not populated, or if we receive a new quarter's worth of data and that new quarter file has a lot of missing or blank records, we'll flag that. So there are several data validation processes in place that we use before ever publishing this data. And that's kind of the lag between when the data is received versus actually publishing it. There's about a week or two lag that we take internally to make sure we are publishing correct data. Because there are some instances in which the discharge data is not always perfect, although hospitals incur financial penalties if they submit their inpatient data and it's got a lot of data quality issues that don't get quickly remedied or addressed. So hospitals do actually have a financial incentive through these regulatory reporting requirements to make sure their inpatient data is as clean and standardized as possible. But even then, there are still, sometimes if a facility gets acquired, or a facility shuts down, or there's a merger, there could be some nuance there. All right. Flip asks, what are the mental, behavioral, and neurodevelopmental flags? Are these indicative of the birthing person or child, or both? Good question. So the mental, behavioral, and neurodevelopmental flag is, so because we can pull all the ICD-10 codes for the birth for both the mother and the baby, we can also flag in-hospital birth events with these mental, behavioral, and neurodevelopmental ICD-10 codes, which are defined as any ICD-10 code that starts with the letter F. I know that's kind of sounds like an arbitrary definition, but it's actually the way that mental, behavioral, and neurodevelopmental ICD-10 codes are categorized is any ICD-10 code that starts with the letter F. So if there is an ICD-10 code for an in-hospital birth event, even if it's the 30th ICD-10 code and it's representative of depressive neuroses, we will include that, and it'll show up as a discharge record with mental, behavioral, or neurodevelopmental ICD-10 codes present. You can see the pretty linear increase of those ICD-10 codes being captured across the state. And these are reflective of the birthing person specifically. It is not reflective of the child. As I mentioned earlier, all of the record counts that you're looking at are only reflective of the birthing person, of the mother in this case, for maternal health. So, but once we create that mirror dashboard that looks specifically at newborn only, and we can just overlay the same diagnostic methodology to flag mental, behavioral, and neurodevelopmental things and go from there. So it's in the works, but right now you can see those ICD-10 code trends for the birthing person specifically. And you can definitely see the, like I said, pretty linear year-over-year increase in the amount of in-hospital births that have these ICD-10 codes present. All right. Any other questions? Continuation about the data on neonates. Will you be able to link data on mothers to the data on neonates through a unique identification? Yeah, what's created in the future? Another really great question. So the way that the discharge data comes in to the association is that it's at the discharge level, not at the patient level, meaning that the primary key, I know this is kind of pretty dry data stuff, but the primary key or the identifier that we use to distinguish distinct records is at the discharge level. So the same patient can come in for 5 different inpatient admissions and they'll all have different discharge keys, a different primary ID, if you will. So there's not really a very straightforward way of tracking patient activity in the hospital. We're really just looking at overall discharge volumes, since we don't have that patient ID. That being said, we have, as the association, been investing a lot of financial resources in a mapping project where we are using demographic elements that we receive from the UB04 from the patient, like their social security number and their date of birth, to map these discharges and do that exact thing of being able to track activity in the hospital. We don't have that availability between linking the mother and the newborn right now, but we will definitely. I think in the near future, after that continued investment of trying to link everything together. But right now, everything's pretty much at the discharge level. Any more questions? I know this is a lot of info, but want to make sure I got to everyone here. All right. So I'll go ahead and stop sharing and we'll turn it back over. Really appreciate the time. And I will be putting in my contact information in the chat if you have any questions and want to reach out and follow up. Thank you.
Andre and Evan, thank you so much for such a comprehensive presentation. Love all the questions in the chat. Please don't hesitate to reach out to our speakers after the event to follow up and learn more. As a reminder, this is the first webinar in a series. Our next webinar will be on April 9th and include presentations from DMAS on the healthcare effectiveness data and information set. Subsequent presentations will be on May 14th with VDH Office of Family Services. June 11th from VHI on the all-payer claims database and the Emergency Department Care Coordination Program, and concluding on July 9th with the VDH Office of the Chief Medical Examiner on the Maternal Mortality Review Team. We hope you'll join us for future webinars and share this with your friends and colleagues. Thank you so much and have a great day.
Thanks, everyone. Bye-bye.
Thanks.